Hi guys, welcome back. The next topic we're studying is rheumatic fever and rheumatic heart disease, and I'll be discussing updated Jones criteria with you. In fact, most of the time in the exam, they love to ask about these updated criteria, both the major and the minor ones that I'll explain to you in detail. First, we have a look at the baseline information for this topic. It's an example of type 2 hypersensitivity reaction. Well, the organism responsible will be group A, beta hemolytic streptococcus. This can be responsible for either causing skin infections or contributing to recurrent sore throats. And when it comes to rheumatic fever and if our development of rheumatic heart disease, it is recurrent sore throats that are relatively more common etiology wise. The patient is going to be 5 to 15 years of age and he has these recurrent sore throats and keeps on coming to a clinic on a regular basis. Now, because of this recurrent sore throats, obviously because there's a bacteria involved, there would be antibodies produced against it, and the antibodies in this case will be then neutralizing the bacteria. So let us hypothetically take this rectangle to be the representation of group A beta hemolytic streptococcus, and on the surface of this are the targets of these antibodies. You are aware from your microbiology class that this bacteria will be having M protein on its surface, and the bottom line is that this antibody is like a laser guided missile. Like the missile locks onto the target and destroys the target. Similarly, here this antibody is supposed to latch onto this target and help in destruction of the bacteria. But the bad news is that this antibody actually will cross-react with certain components of connective tissue whose chemical structure can be identical to that of M protein. I am teaching you regarding type 2 hypersensitivity reaction, where the antibodies will obviously try to attack the bacteria, but they might start attacking self tissues also. So the first MCQ that we're going to discuss here from the exam perspective will have a microbiological overlap also. The question in the exam said that what is the name of the antigen and where is it present, whose chemical structure is same as that of M protein and therefore the antibody is cross-reacting. So we need to understand that this component that I'll discuss with you will be present everywhere in the body. I can call it omnipresent. This component of the connective tissue is technically called as N-acetyl glucosamine. The point to be understood is that the antibody is getting confused because both of these antigenic targets will look the same to it. So it will start attacking the self-human body, and this results in development of creation of Ashkoff nodules. In fact, lots of time they can correlate this with pathology as well. So no big deal. They can give the exact image which is given in Robbins for Ashkoff nodules, or if they might even zoom into that view of Ashkoff nodules, you will be able to notice regarding these particular cells which are called as Anishkov cells. Now the problem with these Anishkov cells per se is that one, they have this peculiar terminology. Why they call it peculiar is because the nucleus of this cell per se will look like a caterpillar, the serrated appearance. So the pathognomonic feature of this condition is Anishkov cell, which is also taught as caterpillar cells per se, and the histopathological image of Ashkoff nodules is obviously to be read from the pathology domain. And in fact, one or two choices in the MCQ can be these details that are taught in the paraclinical subjects as well that I've highlighted. Two important carry home messages from this slide are N-acetyl glucosamine is the target against which the antibody will cross react, and caterpillar cells / Anishkov cells are going to be the pathognomonic feature of this disease. Now let's look at how the disease will evolve. And per se guys, connective tissue is everywhere, no? I mean, connective tissue will be in the heart valves, it will be in the brain, it will be in the skin, subcutaneous tissue. So that is why you get neurological features like chorea. There can be endocarditis component developing, or there could be subcutaneous nodules developing, and even to the level that even the joints can be involved. So you could either be having arthritis or even arthralgia. One of the very prominent updates that I want you to remember for Jones criteria is that now even subclinical carditis, what I mean by subclinical carditis is echocardiographic findings are also a part of the major criteria. The most of the criteria are almost the same, just a finer nuances are there which I'll explain to you in the form of low endemic area, high endemic area zone. Low endemic area would mean, like for example in America, where development is more, so sore throat incidence would be lesser, and in our country because of overcrowding, because of our population, the incidence of sore throats will also be more and incidence of rheumatic fever will also be more. So India per se will be a high endemic zone. So they have subdivided this into low endemic and high endemicity, which I'll explain to you as we progress. But one of the most important things that I want you to remember is that echocardiographic criteria have also been added to the major criteria. This is 2015 update, because last time these criteria were updated were way back in 1992-93, but then the 2015 update is the one which is usually asked by the examiner. We will first focus on the major criteria that will take me some time to explain, so please be patient. And one of the important ones to be remembered is the carditis component. They can be pericarditis, myocarditis, endocarditis. Any of the three layers of the heart can be involved. And obviously, if it is endocarditis, that is when the valvular lesions would be occurring. Now, what is highlighting currently is that why do you want to wait for valvular lesion like mitral stenosis or mitral regurgitation to develop and then say that, okay, you are having rheumatic heart disease? He says that even if you are able to identify the valve inflammation by echocardiography, you can actually be having even a subclinical carditis. What I mean by subclinical carditis is, let us take this to be a representation of any of the heart valves, because mitral is the one that is usually involved. So what I'm showing in this diagram is inflammation of the valve cuffs. You see, in this condition, Ashkoff nodules can be in the superior surface of the heart valve, inferior surface of the heart valve. But yes, Ashkoff nodules are found in substantially high area, concentration in this area where the valve cusps are touching each other. So the tip of the valve which is touching one another is called as commissural ends, or you will just read the technical word valvulitis. The importance of this valvulitis is that because of the inflammation present here, the valve cusp may not be able to approximate properly, and there might even be leakage of blood. If the amount of leakage of blood is very less, the murmur may not be appreciated. You see, when you are in a busy OPD and with lot of noise and cacophony in the background, there's a high probability that in a busy OPD you may not be able to appreciate a murmur because of the background noise or the ambient noise. So he's saying that why do you wanna miss out a case just because you were not in a proper setting? If echocardiography can pick up this valvulitis, then even then, without or the presence of mitral stenosis, mitral regurgitation, or valvular lesion, we can say it is rheumatic heart disease, because after all, this is the starting of the disease. Once the disease will evolve, that is when valvular lesions will develop. Our objective as a doctor is early identification of the disease, and that is why I'm highlighting this particular domain that they love to ask. Subclinical carditis slash valvulitis is also now a major criteria. I will now be mentioning regarding clinical carditis also. There can be development of rheumatic pericarditis. Now let us see how rheumatic pericarditis will evolve. This is the same kid, 5 to 15 years of age, recurrent sore throats. And today this child is having severe episodes of chest pain, which is present at rest also. Now maybe a 5-year-old child may not be even able to tell you that I'm having chest pain. So all he is doing is crying and he did not go to school today. In those circumstances, when this child is brought to you, obviously crying child is very difficult to manage, but somehow you were able to calm down the child, or the mother was able to calm down the child. And when you are auscultating the kid, you will be hearing a scratchy sound in the chest. This scratchy sound in the chest is called as pericardial friction rub and can be easily differentiated from pleural rub, because pleural rub is related to breathing, but pericardial friction rub is independent of breathing per se. This is going to persist even on breath holding. The scratchy sound in the chest will persist on breath holding, whereas pleural rub is mainly present on inspiration. Now, once you're able to differentiate that the scratchy sound that you're hearing is a pericardial friction rub, you want to be sure that is this an artifact? Is that something related to a stethoscope that is causing this, or is it actually a genuine sound that you're hearing? You can definitely supplement this by doing ECG. And you were surprised because this child was having a global, I'm saying global because pericarditis will be all around the heart. So the child will having a very characteristic ST elevation with a concavity in upward direction. So that definitely gave credibility to your diagnosis that this child with recurrent sore throats is having now a rheumatic pericarditis. The main message is pericarditis will contribute to chest pain due to irritation of the phrenic nerve, and for the treatment of this condition you are mainly gonna use steroids. Do not answer aspirin. We use aspirin mainly for management of the arthritis component, but for the chest pain component, the inflammatory component, we shall be using steroids. There is also a possibility that the Ashkoff nodules might be damaging the myocardium, and therefore you could have a rheumatic myocarditis. Now, if it's going to be a myocarditis, then the bad news is it can even trigger a acute congestive heart failure. Whenever there's going to be a heart failure, the heart will dilate, and this can contribute to development of a functional. I'm saying functional because at the moment there is no fundamental difference to or damage to the valve leaflets. It is early part of the disease, so only because the heart is dilated, the tricuspid annulus will dilate, the mitral annulus will dilate, and therefore there could be a functional MR or functional TR developing in the patient, and this functional MR will worsen the pulmonary edema component. Therefore, in rheumatic myocarditis, in the first presentation of rheumatic myocarditis, because he's having acute pulmonary edema, Therefore, we will have to use a couple of drugs that I've highlighted, that is LMNOP, Lasix, morphine, oxygen, and positioning. I've discussed that even in congestive heart failure component that we will be using Lasix, that is a diuretic. Why do you use morphine? Because morphine causes shunting of blood from pulmonary to systemic circuit. In simple English, it means that the blood will be shunted away from the lungs per se, so the pulmonary edema component will reduce. Nitrates, why? Because nitrates reduce preload as well as afterload. So they are going to reduce the load on the heart, oxygen to obviously give some fuel to the starving muscle. And then positioning is important because all patients of congestive heart failure, the head should be higher as compared to the legs. Why? Because if the legs are relatively lower, then the venous return to the heart will be lesser. So the load on the heart will also be relatively lesser. When it comes to myocarditis, it can also contribute to ST segment changes, but they're relatively non-specific ST segment changes. You see, I want to highlight that if it is going to be rheumatic pericarditis, then there will be definitely a ST segment elevation, which is concave upward, and this ST elevation will be present in almost all the leads except one, that is AVR. You are anyway familiar from the ECG discussion that AVR is always going to behave opposite of the standard leads. In AVR P wave, the first wave of the ECG and the last wave of the ECG is upside down. It is negative. So you will get a ST depression, that is a mirror image. Myocarditis can also have non-specific ST segment elevation or even non-specific ST segment changes. So I'm not commented on the ECG finding per se because it is non-specific. Now, most examiners are very interested in clinical carditis because they want to see your knowledge of rheumatic endocarditis. And because of this endocarditis component, the valvular lesions will be developing. Patients could be having, it can either be any one of these or all three of these. As they teach you in pathology, multiple layers of the heart can be involved simultaneously as well. For endocarditis, I would like to subdivide the discussion into which valve is commonly involved. You very well know that is going to be mitral, but I'll put up a question before you: which valve is usually not involved or rarely involved in rheumatic etiology? Then we will talk about what are the common valvular lesions that are seen. You are anyway aware of mitral stenosis developing in the patient. And lastly, I will speak regarding which surface of the heart valve is involved per se. That is going to be the commissural ends. Now, when we talk about the valve involved per se, as I've highlighted, the most common valve involved is mitral, but the question was asked vice versa: which heart valve is usually not involved in rheumatic endocarditis? It is going to be the pulmonic valve. In contrast, when it comes to valvular lesion per se, in adults, it is definitely gonna be mitral stenosis. But if he gives you a question in pediatrics, he mentions 5-year-old boy diagnosed with rheumatic heart disease, which is the commonest valvular lesion, your answer will be mitral regurgitation. Please remember, for pediatric age group, it is gonna be mitral regurgitation. For adults, it's gonna be definitely mitral stenosis. In lots of cases, it can be concomitant also. Na? MS with MR can also be there. Now let us look at how the examiner will play around with words. There is a distinct possibility that in some questions he might say the word rheumatic active carditis, or he might say rheumatic carditis. Now look at one word that will change the entire domain. What I mean by active carditis is the initial presentation of the disease. That's a pediatric presentation. So the answer will be mitral regurgitation. And if he says plain carditis, it means a chronic presentation, long-term presentation. That's going to be mitral stenosis. The same information which I mentioned superiorly has once again been discussed, but in a different way. You can see that the word active per se is making one word of a difference. I mean, when you're reading a question fast, no, there's a high probability you might miss this word and end up as answering it as mitral stenosis. So be very careful with the terminology that you're reading. And when it comes to rheumatic endocarditis, pediatric, early presentation active disease is MR, later presentation is MS, and then both of them could be involved simultaneously as well. As far as the surface involved is concerned, I've already explained that to you, but I'm going to discuss another domain here. So listen to this representation once again. What I said was that Ashkoff nodules could be involving superior surface of the valve, inferior surface of the valve, but max involvement is seen of the tip of the valve. So in pathology, they will use this classical term, commissural end involvement is seen in patients of rheumatic endocarditis. Because of this, the coaptation, the valve leaflets should be touching each other tight. In this case, the coaptation is not proper, so there can definitely be leakage of blood between the valve leaflets. As a result of this leakage of blood, there would be two things that would be happening. One is again from pathology domain, because this blood will go and it will strike the left atria per se. So you will always read regarding McCollum's patch. It is itself a question. No, McCollum's patch is encountered in the free wall of the left atria. I want to highlight that again, free wall of the left atria due to the blood moving like this. Now the issue is, I'm also going to hear a murmur in this case because blood is moving from left ventricle to left atria. Now listen to the words very carefully, guys. The blood is leaking from LV to LA, but it is very minuscule amount of blood. It might be only 0.5 ml blood, it might be only 1 ml blood, because the volume of blood at the moment is very less. The murmur may not be heard initially. But all this blood that is going from LV to LA, that's the critical point. All the blood that is going from LV to LA ultimately has to come back also, no? But there's venous return coming via the pulmonary circuit into the left atria, right? The blood is oxygenated via the lungs. Now the venous return to the left side will be met with this blood that is leaking from LV to LA. So the combination of this blood, that is extra blood. Why I'm saying extra? Because venous return is also coming, and this blood from LV to LA is also reached in the LA. So LA of this patient is dilated and is having more blood than normal. All this blood will flow back into the left ventricle and will create a flow murmur. I repeat the fact once again, the murmur which will be heard in this case will be a flow murmur. Why I'm speaking about the word flow murmur is because the blood leaked from LV to LA. It will cause dilatation of LA. Now it's going to be met with the venous return, and the combination of this increased blood will come back. So because more blood has to travel through the valve leaflets, it will cause more separation of the valve leaflets, and it can actually contribute to turbulence also. The flow murmur that I'm talking about here, and I've been so descriptive, guys, is the most important statement that I'm making for the second slide for this discussion. Kerry-Coombs murmur, oft asked, characteristic murmur of rheumatic etiology is, it is going to be answered by you as a Kerry-Coombs murmur. Then he can also ask you about the timing. So if he says what is the timing, then in Harrison, Kerry-Coombs murmur is given as a description of mid-diastolic murmur. The logic is saying is that because maximum blood flow into the ventricles occurs in middle of diastole, so it is a mid-diastolic murmur. In contrast, the word is mid-diastolic murmur. Why? Because the blood is reaching into the ventricles in the middle of diastole. That's where the maximum blood flow into the ventricles is, rapid ventricular filling. But in some books, it is also given as late diastolic murmur, especially from the pediatric domain. Now, how to solve this question? Please remember, suppose in the exam, the usual options are early diastolic and mid diastolic, because two options will be systolic. Two options will be systolic, like ejection systolic, pansystolic. Two options will be diastolic. So majority of MCQs, you will notice it will be written early diastolic and mid diastolic. So the answer would be given as mid diastolic. That is what Harrison is saying. But suppose he wants to make it more technical. He says early diastolic, mid diastolic, late diastolic. So for this highly technical question, then the answer will change towards a late diastolic murmur. I want to resolve the controversy here, guys. See, I could have mentioned only one of them and I could have moved on. I've tried to make you aware of this controversy from medicine versus pediatrics. Harrison mentions mid-diastolic, some pediatric books mention delayed diastolic murmur. The controversy can be solved like this. If it's asking you to select between early versus mid, answer is mid-diastolic, as is mentioned in Harrison. I quoted it. If it is going to be early, mid, late, then it's going to be late diastolic murmur. And well, why should I wait for this murmur to actually appear if it's going to be documented early? That is what I started the discussion with. If I can pick this lesion early in the form of valvulitis, then the diagnosis of subclinical carditis is sufficient for diagnosis of this condition. At this junction, I also want to say that he has subdivided the discussion of rheumatic fever into low endemicity versus high endemicity. So I'll just go back to my previous slide to add these details with respect to modified Jones criteria. The meaning of the word low endemicity, though this is more of PSM domain, but one should be clear about the values here, is less than 2 cases detected per 100,000. The denominator is obviously to be listened with care. It is less than 100,000 cases of school age population. The denominator, I repeat once again, incorporates mainly school age population. Now, there is an alternate definition for it, which is the reason why I'm highlighting it. In lot of books or notes, you will notice it is written as less than 1. So a lot of guys send me this query, sir, you said less than 2. In XYZ notes, it is written less than 1. There is a difference in the denominator, guys. In some books, it is written less than 1 case per every 1,000 cases. But in this particular case, they're not taking only school age children. They are taking all age population. I want to highlight this disparity once again. Meaning of the word low endemicity is less than 2 slash less than 1. If it is given as less than 2, it is going to be 100,000 cases of school age population. If it's going to be less than 1, it's all age population. So, I mean, anything value, it can be either of the two values given in the question, and you have to be aware of both of these. Otherwise, the disparity usually comes is, sir, you said 2, somebody else said 1, vice versa. So, I've just tried to clear off that particular part. As I've highlighted, echocardiography has been included in the diagnostic criteria of rheumatic fever for subclinical carditis, and then there's a clinical carditis component that would also come up. Now, assuming the fact that the case was not diagnosed on time, then valvular lesion of MS will occur, and there would be a characteristic murmur that can be given in the question, that is mid-diastolic murmur with a pre-systolic accentuation. Why I highlighted that? Because I taught you Kericum's murmur is a flow murmur. It's a plain mid-diastolic murmur. If he adds the word pre-systolic accentuation, you can go through the murmur section. I've spoken about it. If he adds the word pre-systolic accentuation, that means mitral stenosis has already developed. Obviously, there will be supportive evidence also given in the question, like he might talk about a loud opening snap. He might talk about a loud S1 and then even a loud P2 due to pulmonary artery hypertension. But I just want you to be careful, because when you read the word mid-diastolic, there can be error of judgment. You might answer it as mitral stenosis. You might answer this as Kericum's murmur. The pre-systolic accentuation word should be written. In pediatric age group, if it is MR, mitral regurgitation, then there's going to be pansystolic murmur with a uniform intensity all through the duration of systole with a soft S1 present. He can also quiz you regarding management of this rheumatic heart disease patient with severe mitral stenosis. If the orifice area is less than 1.5 square centimeter, normal is 4 to 6, then the patient will be requiring a percutaneous mitral balloon valvotomy to ease off all the back pressure changes. But if the same patient will not get treatment done, and unfortunately there is a calcification developing in the valve, in those circumstances you will not be deploying rather a balloon. Why? Because the moment you deploy the balloon, guys, this valve will break into pieces, like a cookie will break into pieces, or a cake will crumble into pieces. So you will be forced to deploy a prosthetic valve in the patient. In contrast, if he says what is the treatment for mitral regurgitation, which has a pansystolic murmur, we will try to repair, because there's going to be damage to the papillary muscles, there's going to be damage sustained by the quadrate and DNA, so valvuloplasty will be done in the patient. These are additional aspects that can be written as a sequelae or manifestations of endocarditis in a patient, and most of the time in the exam, the examiner is interested regarding the endocarditis component, so I spoke a little more about it. We come to the second major criteria. At the moment I've discussed only one, the carditis component. I'm now going to describe the arthritis component of the disease. Why? Because the antibodies are going to attack the same connective tissue component. Arthritis is also a early feature of the disease. What I imply by early feature is that if a child with recurrent sore throats will develop rheumatic arthritis, it can develop as early as within 2 weeks of these recurrent sore throats. Now let us see what the parents have to say. They said, sir, this child woke up in the morning, was crying a lot, and he was walking with a limp. So the mother noticed that the child is walking with a limp because he's having an ankle joint swelling. When this child is trying to walk, because of the pain component, he may not be able to go for defecation, he may not be able to take a bath, so the mother had to help him across. Subsequently, after a few days, the swelling of the ankle joint might actually reduce or disappear, and the swelling of the knee joint will appear. And then after a few days, the swelling of the knee joint will disappear. Maybe the swelling of the elbow joint might appear. And it is not that only left ankle, left knee, left elbow might be involved. It could be left ankle joint and right knee joint, and then maybe again a left elbow joint as well. I mean, there's no pattern per se. Any joint can get involved, and the arthritis is jumping from one large joint to another. So because of this jumping character, we are going to call it a migratory polyarthritis. I'm not saying that all joints are involved simultaneously. I'm saying one after the other. Most of these patients, because of the migratory polyarthritis component, they would be loss of disability and the child will not be able to walk. So your job as a physician will be to start this child on aspirin. If aspirin is not working, you might even have to use naproxen in the patient. Normally we use naproxen like for severe pain situations like migraine. But here aspirin and naproxen have been found to be highly effective. With aspirin, they love to talk about this side effect, that is Ray's syndrome. Now, please appreciate my next statement very carefully. It is not alone aspirin which is the villain here. Because if that was the case, then everybody taking aspirin, like for chronic stable angina or for cardiac causes, would also develop Rett syndrome. Whenever you are having a combination of aspirin administered when a person is having a viral infection like varicella zoster, a person was given aspirin while he was suffering from, let me say, influenza B infection, the combo of the two is the one that causes damage to the liver and causes Rett syndrome manifestations. The presentation will be just like hepatic encephalopathy, but there won't be any jaundice. Repeat the fact once again. SGOT, SGPT will be going through the roof. Features of hepatic encephalopathy will develop, ammonia intoxication will develop because of damage to the liver of the patient, but at the same time, jaundice is not found in Rett syndrome. That's anyway a concept that I want you to remember, that it is an icteric presentation. Raised serum bilirubin is usually not grossly elevated. Now, the joint involvement will definitely cause problem for the patient, and lots of time he can mix up this information with that of rheumatoid arthritis as well. In some questions, instead of mixing up the information, he will also have the flexibility of talking about low endemic zone versus a high endemic zone. Low endemic zone can be, for example, America, where obviously due to good hygiene, sore throats will be lesser, so the possibility of arthritis component or per se rheumatic fever will also be less. He says for low endemicity area like America, you have to demonstrate multiple joint involvement one after the other, so migratory polyarthritis has to be there. But for something like India, where the disease is relatively common, he says, why do you want to wait for one joint to be involved, the next joint to be involved, and the next joint to be involved, and let the child suffer over these days and then say, okay, you have rheumatic arthritis. He says if the child is having even a monoarthritis, I repeat the fact once again, in a high endemic area like India, because of the high incidence of the disease, I don't want to wait for multiple joint involvement to occur over a couple of days, causing disability, distress on the part of the parents. He says if you document a monoarthritis component, it's more than sufficient. Obviously, in a high endemic area, if migratory polyarthritis is already present in the history, no problems with this. But as I've highlighted, our objective as a doctor is always to go for early diagnosis. So I would not like to wait for multiple joint involvement to occur in a patient. And then he has included another term here, polyarthralgia. Now this is obviously to be taken with a lot of, I would say, caution, because you see, polyarthralgia means pain, not inflammation, means pain in the various joints. So other differential diagnosis should also be considered. If suppose a child is having fever with pain in the joints, it could be chikungunya also. Even in COVID-19, you will read about people and children complaining of pain with fever in the joints, right? So the point is, polyarthralgia is something which I just put a star mark to highlight. It should be interpreted with caution because all other illnesses have to be ruled out. But these are terms which are added in the literature. The ones that are put a star mark are must know for you. Why? Because earlier when I was a student, all we used to read was migratory polyarthritis over. But now monoarthritis and polyarthralgia are also written with respect to especially a high endemicity area, like for example India. For America, obviously the standard presentation has to be there because the disease incidence is relatively lower. So this minor difference should be definitely remembered by you, and that's an add-on. Additional fact that I'll use this opportunity to actually speak before, though the topic is covered in the rheumatology section, but I'm getting this golden opportunity to compare the two diseases before you side on. I'm gonna describe rheumatic arthritis versus rheumatoid. Well, the first difference is rheumatoid is gonna be usually a young female, maybe in her 20s. She's complaining of morning stiffness. She says, I have pain in my hands in the morning. I can't even hold a toothbrush. But then gradually when I start brushing my teeth or moving around, then the pain begins to reduce. When I asked her, ma'am, can you point where the pain is? She's pointing to the small joints of the hand. That's going to be PIP, MCP and the wrist. And if she's pointing to the left wrist joint, she will obviously point to the right wrist joint also, bilaterally symmetrical. But when it comes to rheumatic arthritis, it will mostly be a child. Can be a person, but will be relatively a younger age group. When I talk about adult, it will be relatively younger. In this case, it will be large joint involvement. And this large joint involvement will be jumping from one joint to another and will not be bilaterally symmetrical. It will be rather random. I mean, like today it is elbow joint. Maybe after 2 days, it could be the opposite side ankle joint getting involved in the patient. For the left hand side, that is rheumatoid, the antibody test that we do is called as anti-CCP, cyclic citrulline peptide antibody. Whereas for rheumatic arthritis, the supplemental evidence would be ASO titer, because we are going to have evidence of bacterial infection in the body. So ASO titer will definitely be elevated. On the left hand side, the drugs used would be like methotrexate or leflunomide, or even in the discussion of rheumatoid arthritis, I've talked about tofacitinib. But on the right hand side, I have mainly talked about usage of aspirin and even naproxen in the patient. So there is absolutely no reason why rheumatoid versus rheumatic can ever be missed. And I've just done a quick comparison in this case. And rheumatoid anyway, guys, I mean, one of the important differences that will now come up will be rheumatoid will always be an example of erosive arthritis, no? Because you always in rheumatoid arthritis will be having either a Boutonniere deformity or a swan neck deformity, Z-line deformities. I mean, rheumatoid per se will always cause deformities in the hand, whereas the right hand side rheumatic is an example of non-erosive arthritis. The points to be remembered is point number one, you should be able to identify these words in the question. Monoarthritis, polyarthralgia are included in the major criteria for a country like India. Second point to be remembered, remaining no migratory polyarthritis stuff you are all aware of. I am just highlighting what you should be knowing from 2015 update. That's the one that is usually asked, and the differences which he can mix up in the question. You see, he'll say, he'll give you a case, and then I'll say which of the following are correct statements about the presentation of this patient. And he can obviously, mix up the information. So while you are reading fast, there can be errors of judgment. And that is why I've utilized this opportunity to talk about rheumatic arthritis component. I will now be explaining to you neurological manifestation of this patient that is called as Sydenham's chorea. While I'm writing it, the question for you guys and is asked by examiner is which part of the basal ganglia is damaged. While I will write the lesion before you, I want you to remember that how will chorea present. Chorea is going to be involuntary movements in the hands of this person. When I say that, people say, sir, even focal seizure is involuntary movement. Myoclonus jerky movement is also involuntary movement. So what is the difference? See, myoclonic jerks will occur intermittently. Like person will be fine, then suddenly myoclonic jerk. Or there's a focal seizure occurring in the hand of the patient for a few minutes, then it will stop. But in this case, you will be having a regular continuous movement. So the message is that when it comes to chorea, there will be a regular involuntary movement occurring in the hand of the patient, or fidgety hands. I'll put it like this. You see, while I'm writing, one of my hand is busy writing, talking to you, but my other hand is stable on the table. It's not that it's having some involuntary movements. So the message is, when it comes to chorea, this would be continuous involuntary distal movement. It's going to be in the hands. And is it going to be a fast movement or a slow movement? It is important that you remember fast, because there is a condition called as ethiotosis. When we study about ethiotosis per se, this is going to be a relatively slow, excruciatingly slow, slow, writhing, distal involuntary movement, not writing, writhing, right? Like this involuntary movement. So slow, writhing, distal involuntary movement is what I have highlighted for ethiotosis. The site of lesion is still to be discussed, which basal ganglia is affected. When it comes to hemibellismus will be like, if you go to a marriage party in India, once people get drunk, they start doing that chicken dance or wide swinging movement of the arms. I mean, arms are going anywhere, and most people in India hardly know how to dance. But you will be having this wild, I'll say, not wide, wild swinging movement of the arms. That is what can happen in hemibellismus. It would be asymmetrical, wild swinging movements of the arms. The speciality is that in chorea and ethiotosis, it is distal movement, but in hemibellismus, it is proximal plus distal involuntary movement. I'm going to write the terms here. Hemibellismus basically means wide flinging movements, which are gonna occur both proximally, that is gonna be at the shoulder joint, as well as distally at the wrist joint. I'll put it like this. If I punch, movement at my shoulder, movement at my wrist, that's gonna be combination of proximal and distal. But if I'm just having involuntary movement in distal, that's gonna be one involuntary movement. If it is occurring fast chorea, if it is gonna be ethiotosis, it's gonna be relatively slow. And it's important that we should also know what is the site of lesion. The site of lesion in Sydenham's chorea, the mother is very distressed. She's asking you, sir, what is going wrong? Why is the handwriting of my child so poor? Because of this involuntary movement. Suppose it is involving the writing hand, the child is not able to color in a box. He's not able to color inside a circle. Like the teacher in nursery class, or let me say he's a little older, the teacher has given some arts related project to the child. Now he's supposed to draw, he's supposed to paint. Because of the jerky movement of the hand, he will not be able to paint inside the boundary, so the color will spill out. Teacher will think he's deliberately doing untidy work. So how does a mother come to know that the child is having a problem? Lots of time in Synonyms Korea is there are complaints coming from the school that this child does untidy work. Earlier maybe his handwriting was very good, he used to do very good in school, whatever the teacher used to ask. But now this child, the complaints are poor scholastic performance. The sites of lesion for ethiotosis is going to be answered by you as globus pallidus. When it comes to hemibellismus, guys, that can be a presentation of hyperosmolar coma that you encounter in type 2 diabetes. Hyperosmolar coma is discussed separately in the endocrinology section. Hemibellismus, the site of the lesion would be subthalamic nucleus per se. So point number one, I want you to be very clear about what are the sites of lesion, and over and above this, I also want you to understand that in Synonyms Korea, the initial complaints from the perspective of a mother who's worried about her child would be a poor scholastic performance. So I'm gonna evaluate this child now and let us see what are the findings that will be seen. In case of Synonyms Korea presentation, mother is not going to remember the history of recurrent sore throats because this is a late presentation of the disease. Arthritis was one of the earliest manifestation. I said early, it is actually the earliest manifestation of the disease. It can occur as early as within 2 weeks of a sore throat, but this late manifestation usually occurs after 3 months of a recurrent sore throat. So I'll put it on myself. No, if I had a sore throat 2 months back, I won't remember it. If I had it a couple of weeks back, there is still a possibility that I might be actually able to tell the doctor about it. So this is itself a question: which of the following is a late manifestation of the disease? The answer is going to be given as Synonyms Korea. The site of lesion in this case is going to be caudate nucleus, and there's a poor scholastic performance. Most MCQs will begin by writing poor handwriting of this child or poor scholastic performance, as I said. And here I want you to be very careful, because suppose I gave you a case of a 14-year-old boy who was very brilliant in his junior classes. Now at 14 years of age, his handwriting has become poor. He has become a little aggressive. Personality issues are there. Teacher are thinking maybe due to puberty, he's become a little aggressive, a little cocky, I would say. But the point is, there is a scholastic performance which is dipping in the child, and he's also having liver cirrhosis. Got it, guys? If I'm talking about personality changes, if I'm talking about aggression in a child, if I'm talking about involuntary movements, poor handwriting, and a concomitant cirrhosis, I'm talking about hepatolenticular degeneration, that is Wilson disease. So both in MCQs of Wilson disease as well as in Synonyms Korea, there will be a decrease in the scholastic performance of the child. But obviously in Wilson disease, he will have to give you features of damage to liver like recurrent ascites, caput medusae, portal hypertension, splenomegaly, hematemesis. He has to talk about decompensated liver disease in the patient for you to suspect Wilson disease, or he can give an image of the KF ring. The main message I wanted you to understand, or what I wanted to convey to you, is that there are two MCQs where they can give a question on poor scholastic performance in a child. One is going to be Synonyms Korea and second is going to be Wilson disease. In Wilson disease, obviously liver decompensation features will be written. Now, because this child was noticed to be having involuntary hand movements by you, you are trying to do some tests in the child to actually prove to the mother that, well, child is not doing it deliberately. Mother might say he's deliberately doing it. Is janbooch ke karta because he doesn't want to study. So I'm going to ask this kid who's appearing so fidgety and nervous before me that, beta, please take your tongue out of your mouth. If I take my tongue out of my mouth, it will remain stable. But in this kid, you will notice that when the child protrudes his tongue out of his mouth, the tongue will be moving in, or it will be having this movement like a snake's tongue, keeps on going in and out of the mouth. Similarly here, you will notice an involuntary movement in the tongue as well. This is called as darting tongue. This is itself a question. Darting tongue is a feature seen, and the answer would be Synonyms Korea, which is a major criteria for diagnosis of this condition. Other clinical manifestations that can be seen here is called as pronator sign and milkmaid sign. The grip hand part, no? So the word is milkmaid sign. The next finding that I'm going to write after this is also very peculiar. In fact, that is again one reason why they love to ask about this, because they can incorporate neurology with the cardiology aspects. The neurology aspect that I want you to remember here will be finding of hung up reflexes. Now, why that is important, I'll also say before you, because when you read the topic of hypothyroidism, I have mentioned the word hung up ankle jerk. Mark my words here, guys. Hung up ankle jerk is a feature that you will encounter with hypothyroidism. But when it comes to hung up reflexes is a feature that you encounter with the topic of interest, that is chorea. You can again see the minor difference in the terminology, which I don't want you to miss. So I'll repeat the fact once again. Hung up ankle jerk, hypothyroidism, hung up reflexes is a feature that is seen with chorea. The good news is that this disease has a self-limiting course. But lots of time the mother who's so anxious might not be very comfortable when you say it is self-limiting and you say ki it will get cured by itself in the next 6 months. She's saying, sir, come on. I mean, I paid you consultation fees and you tell me that I don't need to do anything about it. The child is suffering and he's not able to eat his food, or his scholastic performance is reduced. He's not able to write, draw, sketch, coloring is not possible. So if it is causing disability to the level that nothing is possible, I can be even using drugs. I usually avoid writing drugs for this condition. Why? Because there can be side effects also. These drugs that I'm writing are highly efficacious. If I give drugs like valproate, haloperidol, or even phenobarbital, definitely the chorea component can be reduced, but the disadvantage of sedation will come in. And with haloperidol, so you anyway know the fact that it can cause drug-induced Parkinsonism also. The basic essence of medical science is first to know any harm to the patient. For treating one condition, you just can't tell the mother, now, okay, one disease is corrected, we have given a second disease to your child. I want to repeat this once again. Majority of cases, the chorea involuntary movement will gradually disappear on its own. The child will do fine. If it is causing a disability, you do have drugs available. I mean, haloperidol is highly efficacious, but it can cause drug-induced Parkinsonism. Therefore, in case I'm saying, if all these drugs are also not working, sometimes you might even have to use steroids in this case. And if you have tried everything, and that is itself a question, the question said, what is the treatment of medically refractory chorea? What I mean by that is that all the drugs on the slide, valproate, haloperidol, phenobarbital, everything you have used, including steroids, and still there are manifestations occurring in a patient, then for medically refractory chorea, we will be using intravenous immunoglobulins. I have talked about intravenous immunoglobulins earlier for Guillain-Barré syndrome. They can also be used in acute idiopathic thrombocytopenic purpura Kawasaki disease, and today I'm highlighting their usage even in Sydenham's chorea. The message is, in fact, why this is important is because this is the last line of rheumatic fever, rheumatic heart disease topic in Harrison. I mean, look at that. In the entire topic, he did not ask anything. He picked up the last line, that in medically refractory chorea, if everything else has been done, including the usage of steroids, then we can use intravenous immunoglobulins for the patient. So most of the time I've seen examiners deliberately asking, rather they ask you obviously rheumatic fever in the exam or rheumatic heart disease, but then one or two options can definitely be from the neurological domain as well. And the main message is that while solving a question of a scholastic deterioration, keep a watch for, has he talked about KF ring, has he talked about damage to the liver or decompensated cirrhosis, because then it's definitely not Sydenham's chorea, that would be Wilson disease in a patient. So that's a word of caution that I would definitely like you to exercise while understanding this topic per se, apart from few basic allied details that I've highlighted. We shall now be focusing on the remaining two major criteria which are less frequently asked, that is going to be subcutaneous nodules and erythema marginatum. Most of the questions revolve around three things only: carditis, arthritis, and Sydenham's chorea. With Sydenham's chorea deliberately asked relatively more because they love to incorporate neurological aspects into a cardiology based question. Now coming to the subcutaneous nodules in a patient, they will be extensor in distribution. He knows the fact that you can mix up the subcutaneous nodules of rheumatoid arthritis versus that of rheumatic fever per se. So that is why he might actually incorporate the information that I will now speak before you. Please remember, both in rheumatoid arthritis as well as in rheumatic fever, the subcutaneous nodules that are found in extensor distribution, extensor would mean like over the olecranon process or over the occiput or over the spinous processes of the vertebra. But the additional point which I want you to remember is that when you talk about rheumatoid arthritis, then these nodules may not only be present over the skin, but they can be found even in areas like lungs. They can break down and therefore they can be a rheumatoid pleural effusion as well. I want to highlight rheumatoid nodules are also extensor. They're also non-tender, but they're not only found in the skin, but they can be found in the lungs. In fact, they can be present in the heart. So you could be reading about heart blocks with respect to rheumatoid arthritis. In fact, these nodules could be pressing or involving peripheral nerves. So therefore, mononeuritis multiplex as a manifestation can be written. I just want you to be warned about the fact that rheumatoid arthritis, there are multiple sites where these nodules can be present over and above the skin. Whereas in rheumatic fever, the subcutaneous nodules are mainly in the skin and they are non-tender in distribution. The fifth manifestation is usually not encountered in Indian population, mainly because of the darker texture of skin that we have. I'll put it like this. You in typhoid literature will always read about rose spots, but you would have hardly ever seen rose spots in Indian population because we are dark skinned as compared to Americans. If somebody is very fair, it's a separate issue and suffers from typhoid. But otherwise, usually in Indian scenario, we don't read about rose spots. And similarly, when it comes to erythema marginatum also, this feature is not seen in Indian population, so I have usually not seen any questions on the topic per se. It's mainly the carditis, arthritis, and the chorea component which is to be focused, and there are 5 manifestations of the major ones. We will now focus on the minor criteria for diagnosis of rheumatic fever. One is going to be obviously presence of fever, so you need to be listening to this data with bit of care because when I was a student your age, this was easy. But now, because he has subdivided the discussion into low endemicity versus high endemicity, so there can be slight disparity in the data and that can cause error of judgment in the final time. Like for example, what I'm saying might actually sound funny to you, but he says the cutoff for when we say fever, which is useful for diagnostic criteria for low endemicity like America, is 38.5 and for high endemicity like India is 38 degrees Celsius. Now why the disparity of 0.5? What he's trying to say is that in India, because of the fact that disease is more common, you need to have a lower threshold. In America, with the disease relatively rare, you need to have a higher threshold. So that is why that disparity is there. Similarly, we'll focus on the component of arthralgia also. Well, when I talk about arthralgia, please remember the fact that when I say a high endemicity area, then high endemicity area should be having mainly a presentation of monoarthralgia, because in India the disease is relatively more common. But when it comes to, let me say, low endemicity like America, multiple joint involvement should be present. I want to also highlight the reason why I put a star mark before arthralgia is because fever with arthralgia can be seen with multiple viral infections also, so it has to be interpreted with caution. Then is the value of erythrocyte sedimentation rate. When I was a student your age, all the textbook used to say was elevated ESR, no cutoffs. But now you will read that for a country like America, high end versus India, I mean the scenarios are different. If I take up a low endemicity country, then the cutoff is higher, that is 60 millimeter fall in the first hour. Whereas when it comes to high endemicity, the cutoff is 30 millimeter fall. Now, obviously, it looks a little irritating when we have to remember two values for the same thing. All I want you to remember here is, or the logic to be used to solve such issues is that for a country like India where disease is common, you need to have a lower threshold because of the common nature of the disease. And in America, because disease is rare, you need to have a higher threshold to actually diagnose rheumatic fever. This could be something else also, because fever with arthralgia will have multiple differential diagnoses. Thankfully, for the next entry, there is no such disparity, that is elevated C-reactive protein. Here the cutoffs in both populations would be more than 3 milligram per deciliter. Now, nobody expects you to remember these cutoff of CRP, but why I highlighted that is because I have spoken about high sensitivity CRP. HSCRP is different from the standard CRP. High sensitivity CRP is for atherosclerotic. It talks about inflammation in the coronary arteries of the patient. And the next parameter is uniform for both the populations. So I'll just write it in capital all across: prolonged PR interval. On this also the query of most doctors is, why is that so? Why are we having prolonged PR interval in a case of rheumatic fever? Well, the point is Ashkoff nodules are present everywhere, so they can even involve the conduction system of the heart. Like this is SA node, this is AV node, this is bundle of hairs. What I'm saying is that there could be presence of these Ashkoff nodules between the SA node and the AV node, and because they will slow down the conduction. See, PR interval always has an inverse relation with heart rate. So therefore, if these nodules will will slow down the conduction. The PR interval will also get prolonged. These are the minor criteria which I want you to remember from the topic. And when I was a student at your age, even TLC was a component of it. But now TLC is not a part of minor criteria. It is to be done as investigation. See, there's a difference between a diagnostic criteria versus a routine investigation. Because if somebody will come to me with fever with joint pain, especially a child, I will even think in terms of septic arthritis. I need to think in terms of routine infections also. So I will definitely do TLC because TLC is going to be very, very high if it's going to be septic arthritis component present. So yeah, we do TLC in clinical practice. You will see your resident writing TLC for a case of rheumatic. But TLC value cutoff per se or TLC per se is not a part of the minor criteria. So there's a difference between the two things. One is a test that you do because you want to rule out something, and one is that test is a diagnostic feature as well. So currently TLC is not a diagnostic feature, but remaining features are important: fever, arthralgia, elevated ESR, the cutoffs incorporated C-reactive protein, and prolonged PR interval in a patient. And now I want to highlight that for diagnosis of this condition per se, I would need minimum two major criteria. In some MCQs, you will notice that you will actually have to pick up the criteria also. Before I write down the new or the second criteria, I wanna here make a very interesting observation which is sometimes neglected by us. I taught you arthritis is an early feature. Occurs as early as 2 weeks of sore throat, and chorea might occur even after 3 months that the mother may not even remember my child had a sore throat. The point is arthritis and chorea. Arthritis is early, chorea is late. Arthritis and chorea cannot coexist. Mark my words there, guys. I said arthritis and chorea can occur one after the other. Like suppose in January 2021, patient had rheumatic arthritis. There's a possibility by April 2021, person will be having chorea, but two together cannot coexist. So this was itself a question: which of the major criteria may not be present simultaneously in a person? They can occur sequentially, one after the other, like January and April, no problems. It can't be that in January there's a rheumatic arthritis also and there's a Stendhal's chorea also, because of the epidemiological aspects that are said with this disease per se. Now, lots of time in questions, you might actually have to pick up the criteria. So it's no big deal that he might just give you a cardiac involvement of instead of two major, he might just include one major criteria. So you will obviously have to pick up two minor criteria, which could be like a ECG evidence given in the question of prolonged PR interval or an elevated C-reactive protein. For initial diagnosis, if there's an initial episode of the disease, the criteria to be remembered are two major, one major with two minor. Sometimes he would love to ask you about the recurrence of episode of acute rheumatic fever in a patient. Then obviously the above two are obviously valid. The above two are obviously valid. I repeat the fact once again. When it comes to recurrence of acute rheumatic fever, the above two are obviously present, because if it's going to be recurrence again, the same thing can occur. Carditis can occur along with arthritis, for example. But the point is, for recurrence, sometimes if major criteria is not present, we can still diagnose the disease for the recurrence on the basis of three minor criteria. So that also as a point I want you to remember for multiple choice questions, that especially when he's going to talk about the recurrence domain, it could be three minor criteria that can be incorporated over and above the ones that I mentioned. I am just highlighting the above two. Why? Because of the fact that they are the primary ones for initial presentation. But if it's going to be recurrence, because there's going to be recurrent sore throats, and most of the time the mother may not get these benzathine penicillin injections in place, so you might even the child will miss the chance to be normal, because you had told the mother, I want to give regular shots of benzathine penicillin, but injections are something which most mothers will not be very comfortable, especially because benzathine penicillin for prophylaxis rheumatic fever has to be given every 3 weeks. So lots of time a mother will say, sir, I don't want injections, can't you write me tablets? You will say, no, tablets are not effective. So she may not take proper prophylactic measures, as a result of which the recurrence episodes can definitely occur. So we need to prove that the patient has had a evidence of preceding streptococcal infection. You see, what I'm teaching you at the moment is referred in the textbook earlier as essential criteria. Nowadays, some books might be using the word universal criteria. The basic summary of what I'm going to teach you on this slide is that how do we know that this is streptococcal infection present in the person or not? Because you need to link up, no, somebody had a carditis and arthritis. Now you need to prove the incriminating agent is group A beta hemolytic streptococcus. So in the current edition of Harrison, that is the 20th one, he has written this word, recommended tests for suspected cases of ARF, that is acute rheumatic fever. The bottom line is, I want to prove to the patient and to obviously myself that there is a evidence of recent streptococcal infection, that is group A beta hemolytic streptococcus is responsible for type 2 hypersensitivity. In fact, in some questions they have even gone so deep that they have asked what do you mean by the word recent streptococcal infection. So it technically means infection with this bacteria in the previous 45 days, and I can definitely demonstrate this with elevated anti-streptolysin O titer. This value of ASO titer may also be different between pediatrics and internal medicine. Like in pediatrics it may be written 333 international units, in medicine it might be written 200 international units as well. Apart from elevated ASO titers, alternative antibody that might be written is anti-DNase, right? B antibody. The bottom line is I want to demonstrate that yes, there is an incriminating agent present. Now suppose I do not have facility for this, then I can do a rapid test also. The test to be answered by you now will be rapid group A streptococcal carbohydrate antigen test. Suppose you do not have facility for even doing these two, then at least your microbiology department or the microbiology technician can set up a throat swab which you can maybe send to a tertiary care place. So there are three tests available, though any of these three can be used, but why throat swab is written inferiorly is primarily to say that you see, suppose the weather is changing and it's going to be very cold, or let me say in winters it is raining or it is snowing, so incidence of sore throats can increase due to overcrowding. Now if I'm having a sore throat, for example, that does not mean that I'm suffering from rheumatic fever per se. So throat swab per se is less accurate as compared to others. If I want a serological evidence, I want to prove that antibodies are the causative trigger behind development of the disease. So ASO titer is the best way, followed by second or third. If any one of these is present along with the major criteria, that obviously will give credibility to your diagnosis. Now once we have understood this additional fact of formerly referred as essential criteria and currently referred to as recommended test, because I want to link up epidemiology with the clinical diagnosis that I made, it is time to talk about treatment of a case of rheumatic fever. I want to remind you once again that if he talks about recurrence, it can also be three minor criteria, though the above two are also valid. Now suppose a person is having arthritis component, so I will be using aspirin. I can use naproxen also, and if in case arthritis is not responding to any of the traditional events that or drugs I mentioned, that is aspirin / naproxen, we can definitely use steroids as well. But on a comparative basis, if they ask you when would you use steroids in a case of rheumatic fever, then do not answer to prevent endocarditis component. No, we cannot prevent endocarditis. The main role of steroids would be one for treatment of chest pain related to rheumatic pericarditis, because phrenic nerve was involved due to inflammatory cause. And secondly, we can also be using steroids in management of severe chorea, which was not responding to drugs like valproate, phenobarbital. The third point I want to highlight is that per se for chorea, your first answer is it is a self-limiting condition. It will stop on its own. But in case it is not mentioned, or he is saying what is the treatment that you can offer to a patient of chorea, just the word plain chorea, not the word severe chorea, then your answer can be given as sodium valproate. We can also answer intravenous immunoglobulins for patients who have not responded to the above treatment, medically refractory chorea as well. And point number 5 is a highly important part of this discussion that I also mentioned earlier, that is injections of benzathine penicillin. Now, the moment you start talking about injections, most mothers will definitely have a defensive body language and they will say, sir, why do you want to give injections to my child? I told her, ma'am, I need to give regular injections to your child. They would be given every 3 weeks. So she's even more, I would say, defensive. She says, okay, 1 or 2 is fine. Every 3 weeks for how long and why? So first I need to convince the mother, why do I want to give these injections to the child? As you are familiar, I want to prevent recurrent sore throats, because if this is not going to happen, every time the child will have sore throat, more antibodies will be produced, there will be more damage. There can be worsening of the pre-existing cardiac lesion due to more antibodies, more immunological damage, or a new feature might develop in the patient, like chorea can develop in the patient in the long run. So prevention of recurrence and prophylaxis is the main reason why the shots of benzathine penicillin are given. They'll obviously kill the current colonization, whatever is present, but I want the child to have a minimal inhibitory concentration in his blood so that the recurrence of this infection will not occur. The mother is a little satisfied now. She says, okay, doctor, you are concerned with the well-being of my child and you're saying that it has to be given for long duration. How long? Lifelong? I'll say, yeah, ideally lifelong. She's again in a conflict mood with you. She says, sir, lifelong, I mean, how is it practical? So, if a question is given to you like this, a 5-year-old child with rheumatic heart disease with mitral regurgitation, and for how long these injections of benzathine penicillin will be given to the patient, your answer options in the MCQ can be 18, 21, 25, 40 years. Please remember, if valvular lesion is given in the question, then do not answer 21 years. It is going to be answered by you as 40 years. And when you say 40, she's again saying, sir, come on, I mean, my child is 5 years of age. For next 35 years, you want him to come to your clinic regularly every 3 weeks for injection. Do you think it is practical? So, in case a mother is not willing for it, the last, I'll tell her, ma'am, this is the last deal that I can give to you. That is 10 years minimum from the date of diagnosis, that is at least till the 15th birthday of the child. So the bottom line is that in the exam, they would love to ask you regarding 40 years of age. Why? Because he knows you might answer it as 21. Now look at the MCQ where the answer will be given as 21 years of age. He will very smartly write 5-year-old child with rheumatic heart disease, but he will not write the valvular lesion because it is not a guarantee that every case will have a valvular lesion. Some cases might only have pericarditis, some cases might have myocarditis, some might have a combination of the two. So it is not a guarantee that everybody has an endocarditis. If valvular lesion is not given in the MCQ, then your answer will be given as 21 years. If she's not satisfied with that, okay, 10 years from the date of diagnosis is the last deal. Now look at how the examiner can play with English words once again. He will say 5-year-old child with rheumatic fever. He has removed heart disease because it's not a guarantee, no, every time the heart would be involved. In those circumstances, the answer will again be given as 21 years. But now look at the last deal that I'm giving to her. If she's saying a no to that, it is 5 years from the date of diagnosis. So I want you to be very comfortable with the information that I've said right towards the end of this topic, because lots of time they put up questions from here. Lot of us, because we tend to read this 21 two times, that gets reinforced in our brain, and what he is asking is with valvular lesion, that is gonna be 40. Let me just summarize this before you, whatever I just said. Suppose they give you an MCQ in which is mentioned rheumatic heart disease with the second most common valvular lesion, valvular aortic stenosis, and he says for prophylaxis with benzathine penicillin, I'm just writing BP here, what is the duration that you would like to give injections? Answer will be 40 years. On the other hand, for example, in the question, he does not mention any valvular lesion. Suppose in the MCQ, he just says the word rheumatic fever, or he just says the word rheumatic heart disease, and he says prophylaxis will be given till what age, then the answer will be 21 years. The main message here is, guys, prophylaxis with benzathine penicillin. You must be very careful in the question with valvular lesion or without a valvular lesion. If it is given valvular lesion, anyone, it is 40. If it is not given, it is going to be 21 years. The backup answers are optional for you. If you want to remember 10, 10, 5, it's okay by me. But otherwise, at least this is the minimum data that I expect you to remember. Now, you explained all this to the mother and she dropped a bombshell. What I mean by dropped a bombshell is she suddenly said, sir, my child is penicillin allergic. And you are suddenly aghast because you had actually not even written in the prescription the word antibiotic sensitivity test. Guys, whenever you are planning to give benzathine penicillin to a child, you must always, or adult also, you must always do antibiotic sensitivity. Without this, if you give, anaphylactic shock can occur. It is good that the mother volunteered this information and I corrected my prescription slip also. Otherwise, there is a high chance of anaphylaxis developing in the child. I'll mention a couple of details of anaphylaxis which is important. One, they have asked which cell is responsible for causing anaphylaxis. Options were like eosinophil, basophil, lymphocyte, neutrophil. So you can obviously rule out neutrophil lymphocyte, right? You have to select between eosinophil and basophil. Yes, guys. Which cell causes anaphylactic shock, eosinophil or basophil? The cell responsible for development of anaphylactic shock is not eosinophil. We are not talking about allergy, guys. We're talking about anaphylactic shock. It is basophils. Then they've asked which cytokine is responsible. Options were interleukin 1, 2, 3, 4. Now, because these are facts, I'm speaking about them fast. It is interleukin 4 released from basophils, which is the troublemaker. And the problem in this patient, why will anaphylactic shock cause death? In fact, it can occur so fast that before you open the emergency tray, patient might die. The cause of death would be swelling in the vocal cords. In the exam, I have seen lot of doctors casually answering laryngospasm. No, guys, it's not laryngospasm. It is histamine-induced laryngeal edema. So I will open up the emergency tray and give the antidote, that is adrenaline, to the patient. This adrenaline that I will give to the patient will be undiluted one, that is 1:1000. The only scenario in emergency medicine where we give undiluted adrenaline to the patient. I repeat the fact once again. The only scenario in emergency medicine where we give undiluted adrenaline to the patient will be at a ratio of, is anaphylactic shock per se. And what test can confirm the diagnosis of anaphylactic shock? It has already occurred. Now you want to confirm that this was anaphylactic shock. Do not answer histamine levels, serotonin levels, immunoglobulin E levels, or urinary metanephrine levels. It is serum tryptase levels which are useful for diagnosis of anaphylaxis. In my case, however, I was already warned by the mother. So the question now comes up is that in a child with rheumatic heart disease who is also penicillin allergic, how will the prophylaxis occur? I repeat the statement once again. This is a child in whom penicillin allergy is already documented. He has suffered from rheumatic heart disease, and the mother is asking you, sir, I don't want my child to develop a recurrent sore throat again, because she, being educated one, is understanding every time the child will have a recurrence of a sore throat, more antibody production will cause more damage. So what are you going to answer in this case, guys? You want to answer macrolides. And what macrolide will you give? Between azithromycin and erythromycin, you will be giving azithromycin to the patient. So be a little vigilant in the question, because if we incorporate this word penicillin allergy, then obviously the entire domain tends to change, and we'll not obviously give benzathine penicillin to the patient. If you get these facts right, guys, you will definitely be able to score well in this topic. And as I highlighted, TLC is no more a part of the diagnostic criteria, though is mentioned even in the recommended test. I repeat the fact once again. TLC will be done because if somebody is having fever with joint pain, some of the minor criteria, I obviously need to think in terms of maybe a septic arthritis. That could be initial presentation. So once you rule that out, then obviously you can confirm the diagnosis of rheumatic fever in a patient on the basis of the criteria that I've highlighted. And especially the cardiac aspects, the arthritis and the chorea are the main aspects which they love to ask in the exam. These are the details which are important. Keep hammering, guys, keep learning, and you shall do great in the future exams. Thank you.